Hello, good afternoon, everyone, and welcome to Cure PSP's Ask the Doctor session number 10. Thanks to everyone who's tuning in today via YouTube and Facebook Live. We're very excited to have you with us today. We hope that you are all continuing to stay safe and healthy. My name is Jacqueline Zendrian, and I am the Vice President of Events here at Cure PSP, and I will be the moderator of today's Ask the Doctor webinar. Today we have with us Dr. Irene Litvan, and she will be covering the ways to improve the quality of life in PSP and related diseases. Please note that this webinar will be recorded and made available on our website in the next few days. The link will be provided in a follow-up email. A quick overview for the platforms we're using today. Please type in your questions in the comments section of the platform you're using, and feel free to use the chat box to interact with each other, but please do not reveal any personal medical information. Also, please note that any medications that are referred to in this video should not be tried unless under the supervision of a medical professional. The questions that Dr. Litvan will be answering today were submitted prior to this webinar. If you submitted a question that was not answered here today, please note that the recordings of our previous Ask the Doctor webinar sessions may cover the topic that you're interested in. Today, Dr. Litvan is here with us from UCSD, which is the University of California, San Diego, and she is the Tash Endowed Professor of Neurology there and the Director of the Parkinson's Disease Movement Disorders Center of Excellence. She is a neurologist specializing in movement disorders, dementia, and neuroepidemiology. One of her major research goals is to identify symptomatic and biological therapies that can improve the quality of life in patients with neurodegenerative diseases presenting with Parkinsonism and/or dementia. To be able to study patients accurately, she has focused her research in improving or developing neuropathologic and afterwards it's clinical and diagnostic criteria that would allow to identify patients more accurately and finding robust diagnostic and outcome biomarkers. For more than 30 years, she has led or participated in several multi-center studies or international task force to develop clinical neuropathologic diagnostic criteria for all Parkinsonism and/or dementia neurodegenerative disorders, including PSP and CVD, for which she received the National Institutes of Health Merit Award and recently the American Academy of Neurology Movement Disorder Research Award and the Uruguayan National Academy of Medicine entrance. Dr. Litvan has published more than 350 peer-reviewed articles and chapters, and she is senior editor of 4 books, including the first on PSP. Since her arrival to UCSD, the center has become a Parkinson's Foundation Center of Excellence, Research Center of Excellence in Lewy body dementia, and a Cure PSP Center of Care. These designations recognize top medical institutions featuring comprehensive care teams that meet every patient need and provide access to clinical studies and experimental therapies while educating healthcare professionals and the community. At this time, I'd like to welcome Dr. Litvan to today's program. Thank you so much for being with us.
Thank you so much, Jacqueline. Thank you for your kind introduction. It is my true pleasure to be here today and to be able to share some of the things we do, as well as hear what are your concerns and be able to help as much as I can. This is a very difficult disease. In fact, all of them are. So it is important to improve the quality of life. So why don't we go ahead? So the next slide, please. So today, major key points will be the management of PSP and the other related disorders. So we can be able to improve the quality of life. If we don't have the right diagnosis, it is very difficult to know the prognosis, to know what are the possible complications, or to enter into research, all important aspects. So I'll briefly mention a few things. I will mostly dedicate myself to discuss the treatment of symptoms, but obviously not all the symptoms. It's impossible to do that in this short period of time. And then I will briefly mention the research at UCSD. The next one, please. So let me start with this. So all these diseases have in common that they have Parkinsonism. And Parkinsonism is the slowness, the stiffness, the difficulty with balance, posture instability, falls. So these disorders that are called overall Parkinsonian disorders is like saying pneumonia. And there are many causes of pneumonia. It could be a virus, it could be a bacteria, etc. Here it is the same. It could be secondary to a real cause that we can identify, such as medications, vascular risk factors, infections, etc. Or it could be neurodegenerative, that is, where cells in the brain die in certain areas, and we do not know necessarily why that happens. It is hypothesized that it is related to the genetics, although there is no gene identified for PSP, and or the related disorders for that matter. There are possible susceptible genes, and there is the possibility of environmental factors, and there are some that can be identified, but not clearly, honestly. So these neurodegenerative diseases can be divided into Parkinson's disease, that is the most common one, and the atypical Parkinsonian disorders. So we're going to be focusing on the atypical Parkinsonian disorders, that is, disorders in which they have features that patients with Parkinson's disease do not have. And those are progressive supranuclear palsy, multiple system atrophy, corticobasal degeneration, dementia with Lewy bodies, and there are familial diseases that I'm not going to discuss. Next one, please. So, how can we say that a patient has progressive supranuclear palsy? So I'm going to give you the classical definition, and that's the one we defined many years ago, more than 20, and basically is based on the presence of early balance problems or falls. Next one. Parkinsonism, that is what I just said, that instead of like Parkinson's disease benefiting from levodopa, there is no benefit, or the benefit is very mild and disappears. Next one, please. Difficulty moving the eyes. In PSP, the difficulty is mostly in the vertical direction, and it could be seen by people having difficulty following the lines when they're trying to read, and so they get very tired. Or it could be that they see double, or it could be that they see blurred, or other things that are found mostly by the physicians when they examine the eyes. Next one. Early problems with speech and swallowing. Go ahead. So it's dysarthria and dysphagia. Difficulty with what we call executive functions. Those are the functions of an executive, like planning, multitasking, sequencing. So those things are the major things. So next one, yes. So what is it about corticobasal degeneration? Well, again, I'm going to give you the classical definition, but in both disorders, there are other forms that I'm not mentioning because it would take too long, that basically at times overlap one with the other. So the major thing in corticobasal degeneration is what we call apraxia. That is this progressive difficulty moving an extremity. You want to move that extremity, but the extremity is not following your direction. That doesn't have anything to do with the slowness. Next one, please. Parkinsonism that doesn't benefit from dopamine, as I just mentioned before. Next one. Dystonia, abnormal postures of an extremity. Next one, please. Myoclonus, jumping of the extremity rather than the typical tremor that is a constant thing, or that it has a rhythm more than anything else. Next one. Difficulty with language, like confusing one word with another, or visuospatially, having difficulty perceiving things. Next one, please. What about multiple system atrophy? Well, there are two major presentations. The basic thing is that all of these diseases are gradually and progressive. They start after age 30 in this case, and that is much earlier than PSP and CVD. And they have one thing that is important, that is the autonomic failure, the low blood pressure when someone stands. Normally, our blood pressure goes up when we stand. Here, patients may have the blood pressure going down and may have syncopal events. Urinary problems such as urgent incontinence or retention of urine, erectile dysfunction in men that is more easily identified. And then either Parkinsonism, that is similar to what I said in the other disorders, or cerebellar, that is kind of an inebriated walk in coordination and speech problems. Next one, please. So early autonomic features, Parkinsonism, cerebellar features, or both, or either. So next one, please. Dementia with Lewy bodies is a disease in which dementia is predominant. It may happen with Parkinsonism right away, or dementia first and Parkinsonism, and it is the enacting of the dreams, visual hallucinations without any kind of medications, and clear fluctuations of cognition. One day you can do things completely well, the other day you can't. Next one, please. So, having given you an overall brief overview of these diseases, I would like to say, okay, let's go and see what is it that we can do. We cannot cure these diseases. We cannot cure Parkinson's either. What we can do is finding palliative or symptomatic interventions. So let's think about the motor problems that is an early feature in these diseases. So the important thing is early physical therapy. And if balance and falls or gait problems are there, that usually they are, they need to be treated as soon as possible. So the person can learn how to overcome the difficulties, the tricks that are needed. Occupational therapy may be also very relevant, particularly to do a home safety inspection. That is, are there rugs that can make someone fall? If there is a problem with vision, do we have little coffee tables? Things that make someone fall, or put all the bars that are needed in a bathroom, etc. It may come that you can do exercises, so you can do them. As much as you do them, the better it is. This happens as well with Parkinson's disease. You do better if you do the exercise, and particularly the exercises that the physical therapists tell you. If you could do those at least 15 minutes, 30 minutes every day, that's great. Great. And you can do so much better. But it may happen that the problem with the walking is quite severe, and so then you may need assistive devices. Here, the use of canes is not very helpful because most patients with PSP particularly, they carry them as an umbrella. So the important part here is to use a weighted walker or a walker that is a wheelchair, light weight chair. See if you can put the next push one time. Perfect. So here are examples of the what I'm talking about. The weighted walker is extremely relevant because you can control the speed, because what it has is, instead of having brakes, it has you can accelerate, so you can really control well the movement. In addition, is weighted, so the likelihood that you're falling with it, if you are within that U, is very unlikely. So it is very, very helpful, and most people say that it is. But at times there is a problem because someone wants to travel, or the wheels are very small, and so the other ones may help. And one thing that actually a patient of mine showed me is that there is this light walker that can convert into a wheelchair. And as you see, you can fold it so nicely, so it is very light. Particularly for women to carry, is so much easier. So what about medications? Well, although we know that the levodopa or the dopamine treatment in general, the best is levodopa, doesn't usually help, it is important to go as high as we can for at least a month to make sure that we truly don't respond to the medication. Because if it's not tried, we don't know, and perhaps someone can benefit from it, and particularly early on. There is a medication that is called amantadine that, if it is tolerated, because it can give cognitive problems, it may help with the gait, although there are no trials that truly show that. But experience of movement disorder specialists suggests that this is the case. Next one, please. What happens if someone has dystonia? We mentioned the possibility, particularly in patients with corticobasal degeneration, they may have these abnormal postures. We don't want to get to those, but if we do have them because occupational therapy didn't help enough, with having an orthosis or a splint or a brace, then particularly if we inject botulinum toxin in the areas affected, the important part is that we can clean or make sure that there is no pain when moving the extremity. It will not bring back the functionality. So if there is apraxia, there is not going to be any possibility that the botulinum toxin would help with that. There are other medications that are used, like baclofen, clonazepam, that may help as well. But they have, they are oral, so it's not going to directly an extremity. That may well be the most important part. One of my patients as well told me that he had dystonia in the legs, and using this kind of I don't know how to call it, but actually is like a footwear then that has some gel as a sole, was extremely helpful. So you may want to try something like that if you have that problem in your feet. As I said, occupational therapy is important, particularly for evaluation of the orthosis or splints or braces, and exercises to optimize the function of a particular limb, or helping in general. Occupational therapy overall is very helpful for standing up, sitting down, and doing things with hands. So that is more dexterity, that is a little bit different than the physical therapist. Next one, please. So we may have eyelid problems, like I'm showing here, that is either blepharospasm, that the eyelids contract and it's difficult to open them, or it may be that the eyes close on their own and there is difficulty opening them. So people can do some maneuvers, but it is important to know that Botox may at times help. In addition, if someone doesn't blink sufficiently, that is very common in PSP, in CBD, and even in MSA as well, it is important at times to use artificial tears. And experts suggest more glycerin, carboxymethylcellulose, polyethanol glycol as the best ones, although others may be as good as well, and to use them frequently as possible. Because you cannot do this every 2 hours, it's hard to maintain. I always suggest perhaps you can do it before every meal, and that would be good enough. And at times, people, when the eye is very dry, may use free lubricants at night because those affect the vision. There could be also other non-pharmacological ways to do that, and is the eyelid crutches. Some people benefit from binocular prisms, although I have to say that most of my patients don't. And it is important to have a referral to an ophthalmologist if there is a lot of retention of tears or treatment for inflammation due to eye drying that cannot be improved with the artificial tears. Next one, please. Okay, there could be speech problems. So initially, it is very important to try to do the speech therapy as soon as possible to optimize the comprehensibility. But if the disease progresses, may come a time, not always, but may come a time that is very difficult to communicate, particularly when the disease is very advanced. So there could be alphabet boards, it could be text-to-speech system or tablet. I have seen some of my patients, and one of them is actually Hispanics, that's why everything is in Spanish there, that use this and is extremely helpful to communicate. So he's very happy and the family is happy because there is a clear communication. Next one, please. So, swallowing. An important thing to do is if there is coughing when drinking liquids, that is the neurological swallowing problem, it is extremely important to do what is called a modified barium swallow test. In this test, what you do is you put different consistencies of food and with a little bit of barium, and the speech therapist looks with a fluoroscopy and sees how the each consistency is swallowed. And then they can make a proper indication. Maybe it is a postural change, somebody that is with retrocolis when the neck is going all the way back, may need to do the tuck chin or chin tuck, or may have the consistency that is different, making it honey instead of extremely liquids, etc. And if someone wants to, and it's important to discuss this ahead of time, so you know what you want and that can be transmitted to your family. That is, if you want to have a percutaneous gastrostomy, a tube that goes to the stomach, and so you can be fed without losing weight and with less, although we don't know how much, infections that may be secondary to the food going into the wrong pipe. The falls and the food going into the wrong pipe, leading to causes of pneumonias, those are the two major causes of death in PSP. And in general, swallowing problems is a major cause of death in pretty much all the Parkinsonian disorders. Well, at times there could be problems that we have a lot of drooling. And so for a lot of drooling, you can do botulinum toxin injections in the parotids. That's the safest of the places. Next one, please. Okay, let me briefly mention a few studies that we have at UCSD. One of them is this study that is to treat the blood pressure when it drops. We believe this is very important because what happens is that if we don't treat the blood pressure when it drops, in the long run, we can have cognitive changes. And this is particularly important for people that have multiple system atrophy. That is the disease that has the major problem with the blood pressure control. Next one, please. So we talked about this neurodegeneration that cells die. So what do we know about that? In each of the diseases that I mentioned, there are proteins that normally exist, such as alpha-synuclein or tau, that they have an important function in the cells. But for whatever reason, these proteins that are part of, for example, the borders of the cells or the pipes that nourish the cell, and that is tau in particular, get altered and the shape changes, the configuration. Let's say that it was like this, like a star, and now it is all like this. And so what occurs, and we know in all these diseases, is that once this protein has changed its shapes, it starts binding with other normal proteins, so it leads to several of them, and then when that are all agglutinated, that are all cluttered in the cell, and so when the cell that is abnormal with these proteins communicate with a cell that is completely normal, it kind of shares that abnormal protein, so the next cell that was normal changes as well and also dies. So we believe that the disease goes from one cell to another in that way. So if the questions are proteins, so one possibility is to use novel treatments that are trying to make sure that either the protein that is abnormal doesn't go from one cell to another, or that it doesn't get formed, or that we can try to slow the formation of that cell. It will not make disappear the disease, because the cells that are dead. We cannot repair those. But what it can do is certainly slow the progression of the illness. Another important aspect is to find markers to make the diagnosis of the disease early. This is extremely important because let's say that you're falling and you go to the doctor, and the doctor doesn't know why you're falling. Which disease is it? So if there would be markers early on, then we can try to use those to give a treatment, particularly those that slow the diseases much earlier. Next one, please. So we talked about how these diseases, next one, please. diseases have different proteins. So alpha-synuclein is important for Parkinson's disease, for MSA, and for dementia with Lewy bodies. Next one, please. Tau is important for PSP and corticobasal degeneration. Next one. There are other proteins for other diseases that I'm not going to be talking about. Next one, please. Next one. So here I'm marking the two major, and next one as well, the two major treatments for PSP and MSA to slow the disease in these both diseases with different approaches. One of them is to try to use what is called the oligonucleotides. Those are kind of ways of getting the gene or the mRNA that follows what the DNA says, not to produce the proteins that are abnormal. So this is one possibility, and this is a double blind, as all the studies that are very serious are. The other one is GDNF. So GDNF is a nerve growth factor. This one is a more invasive study because it tries to use a way to put the nerve growth factor that you cannot put otherwise in any other way directly into the area affected in MSA. So it starts with one of the areas affected. By the way, I didn't mention, but the study with antisense oligonucleotides, what it is done with what is called intrathecally. That is, you put the medication with a spinal tap and you put the medication there because it doesn't go through the stomach. It would get completely destroyed. Next one, please. So there are also studies that we have, and those we have been having for a while, and many of you may have participated, that are to try to search for biomarkers or the cause of this illness. And those are for PSP, for CVD, for dementia with Lewy bodies, the ones that we have, or Parkinson's disease and dementia. So those are the main diseases that we are searching and trying to see whether it could be a blood marker, or it could be an MRI or other imaging. For example, in Forney, what is done is because in corticobasal degeneration, at times the cause could be looking like corticobasal, but the underlying pathology, what we look into the brain, the proteins that deposit into the brain are not tau. It could be Alzheimer's disease. In this one, the patients undergo a PET with amyloid to determine if there is Alzheimer's disease. And then there is later on another PET with tau to try to see if we can identify the different areas that are affected in PSP and in CVD, so we could better diagnose early as well as follow the progression of the disease in a better way. This obviously is experimental, so we don't have the complete solution, but there are newer and newer ligands that go and bind to the abnormal proteins that are being developed. Next one, please. We are also trying to do studies that we initiate, and one of those is what is called a fold meter. And this one is a way to not only alert the person that may have a cause for the disease, although that has not been done yet. sorry, this one is to identify the causes of the disease, and that is being done already. And so it tries to look and see if the problem is walking, is the problem is the blood pressure that drops, if the problem is things that happen as we age, such as arrhythmia, so on and so forth. And the idea is to further develop that and try to see that we can prevent the problem from occurring. Let's say that the blood pressure is dropping. We say, okay, sit down. Let's say that you're starting to freeze. It says, stop there. So you don't get to the major problems. And the other one is to develop a way to monitor the blood pressure all the time. So currently we use a manometer and we do it, but as you're starting to do it, we don't detect when someone is about to fall because the blood pressure is too low. So this would be something that would be continuous, so we can determine that. Next one, please. So if you want, and you are in different areas or you cannot travel, whatever, the important thing as well is to look at this website that is called clinicaltrials.gov. In this website that is done by the NIH, you see all the studies that are worldwide. So you can put the disease that you're interested and whether the study is available, and you can see as well if it's in your area and what the study is about. So it is very, very helpful. Next one, please. So I think that you may have gotten the gist that in order to treat these diseases, we need a multidisciplinary team. For example, ours meets on a weekly basis and includes movement disorder specialists, neurosurgeons, physical, occupational, and speech therapists, neuropsychologists, a nurse practitioner specialized in movement disorders, a social worker, clinical coordinators that try to coordinate everything, a research coordinator, and researchers so we can move forward all the studies that I mentioned and others. Thank you very much for your attention. Next one. I'm ready for your questions now.
All right, thank you so much. We had quite a few questions come in because we had over 150 people register for this webinar, so we'll be able to get to all of them. But the first question that we had come in was, what types of activities or tasks can patients do to create a sense of attachment to life?
Well, I think that the major one is the support of family members. It is wonderful when people get in touch with their grandchildren, with their children, and they feel the love of the family. And I don't think there is anything better than feeling the love of family. However, there are some people that also like a special profession. Let's say that you're an artist and you are interested in that. Well, there is a way to get information about that. You can get it in the internet. You can be completely linked to your particular area and learn about talks that are given, particularly nowadays that we have the pandemic. You can see talks about pretty much everything everywhere, and they're all free. That is phenomenal. Of course, you can have talking books and get the book that you like. So there is music. There are things that you can do, but I don't think it is worthwhile to frustrate yourself with things that you cannot do. So instead of looking to the glass that is empty, look at all the things that you can do and enjoy them, because there's a lot of things that you like in life. And I think you just need to say to your family members, this is what I like, this is what I want, this is what keeps me active and happy.
Great, thank you. So what are some things that we can do to improve the quality of sleep, whether they are medication or non-medication?
Well, there are several things that we can do for that. But the important thing is to know why someone has a problem with the sleep. This is like if you don't know why you have a pneumonia, you're not going to treat it well. So the first thing is to explain to your physician what is the problem so they can tackle the specific things. Things that are being done are, for example, melatonin, and you can find that over the counter, and you can go up to 20 milligrams at night. You use it 1 hour before your sleep. You try to always use it not in a way that is too early, because you don't want people to go too early to bed, nor too late, because that also changes the sleep cycle. At times, low doses of clonazepam may be important. At times, it could be that you may use antidepressants that could be helpful if anxiety is what is the cause. It could be that you may need treatment for restless legs, and so you may need to have iron if your iron is low. You may use gabapentin, etc., or melatonin as well. You may have REM behavior disorder, enacting of the dreams, and melatonin is the right treatment. So again, it is important to know what is the cause. It may be that you're so uncomfortable, you're not able to move, and so someone may help you to move, or there may be things that can be put by occupational therapists, like a trapeze, that can help you to move, etc.
Excellent, excellent. Next question is, my husband has PSP and is developing more issues with gait and balance. He is currently in PT with little improvement. At what point should he start using a walker? And what walker is best with for a person with PSP?
Well, I think I addressed that. I think that the physical therapist is the best person to say, this is time for a walker, but certainly your primary physician as well should be able to tell you that. Particularly if you're very unstable, I think that this is very important. And I show you the the proper walkers. The weighted walker is very important, but it may be that you're not strong enough to carry it, and you may need a light walker.
Great, thank you for reiterating that point. What is considered the most reliable biomarker in PSP?
I wish we would have one. So these are experimental studies. We develop with the NIH a biomarker that is in the spinal fluid that detects one of the proteins for repeat tau that may occurs in PSP. But that study needs to be improved, and ideally we want to have that in the blood. We're far from that. The other thing sorry for a minute.
So we've got 90 people watching today. We're very excited to have you all.
I have like a ghost in my house and turns on the TV, so I have not been able to find why. So that's what happened. I'm sorry.
I have a cat. I'm sure we'll come through the couch soon. Hi.
Yeah.
Were you finished with your answer, or would you like me to move on to another question?
No, you can remind me. I got so excited with the TV.
You were answering a question about biomarkers, and yes.
The other biomarker that we have a lot of hope is the tau with PET scanning. So we started with one that was not so specific. Now we have a second generation that is much more specific, but we're trying to improve and improve. It is possible that this, in 5 years or so, we may be able to find those. And this would be like the amyloid PET for Alzheimer's disease. That would be extremely important. Of course, expensive, and so Medicare needs to be convinced, and so on and so forth. But those are different steps that come along the way.
Great. So another question is, how does Alzheimer's affect PSP care and the disease progression?
Well, at times in neurodegenerative diseases, it happens that one protein attracts another. So at times it occurs that in addition to PSP, some people, not all, develop Alzheimer's disease. And what happens then is that the memory that usually is not affected in significant ways, there could be some forgetfulness, but the person really knows and has learned what has been the event. It just needs a little bit of a clue to remember or to be reminded. But there is no need to say, everything. I'm going to give you an example because this is important. In PSP, what happens is that the person may not recall the information right away. It is like somebody called, you answer the phone, and then your wife or your husband comes or whoever and asks, has there been any calls? And if the person wouldn't have asked that question, the person spontaneously may not have remembered. But just asking that question, then the person that has PSP, for example, or CBD for that matter, or MSA, all of them, may say, oh yeah, your aunt called. So it needs a little bit of a clue to remember. In Alzheimer's, the memory disturbance is much more severe. So even if somebody has answered the phone, you ask the question and the person doesn't remember anything about it. So they cannot learn the information. And that is a major difference. And that's why people with Alzheimer's ask over and over the same question. That is not the usual thing in PSP or the other disorders.
Thank you. Okay, and so we have a question that says, when a patient is in the end stages, when should hospice be considered? What symptoms would make a patient become hospice eligible?
I think that when the caregiver feels that they are overwhelmed and cannot provide the necessary care, they need to discuss that option with their primary. This is an important issue because if you are overwhelmed, you can get, as a caregiver, sick as well. And so then the question is, who's going to take care of that person, right? So you can do as much as you can, but I think a caregiver is very important that the caregiver realizes that they have to have some time for themselves, that there should be another family member, another caregiver come and help so they can have their respite time so they don't get sick, and exercise or going out with a friend, whatever it is, or getting some support from a therapist or a priest or whoever would be important, because this is your loved one and you're trying to help your loved one, and it's extremely difficult to do it 24/7. It is pretty much impossible. So it comes to a point that if you don't have the facilities at home, you don't have family members, or they're busy or whatever it is, and the task is too hard, I think that you can ask for that. You can also ask for palliative care much earlier than that. And that also can be very helpful, because in the visits, there is also not only the physician, but also a social worker, a nurse practitioner. So there is a more comprehensive care than just your physician at that particular time.
Thank you. And I would like to note that our website does have a brochure in regards to hospice and palliative care. So I would encourage all of our viewers to go to psp.org and seek out that brochure as well. Another question we have is someone has a patient that's going to be having a colonoscopy and they're going to be under anesthesia, and should they be concerned, and should there's a special type of anesthesia that you recommend during this procedure?
Not necessarily. What is important more than anything else is that the medication that is given afterwards would not be something that could lead to cognitive changes that are transient, but could be affecting the person. But there is not really anything else. And the person should also say that they have PSP, but I don't think there is any risk more than the risk of any other person without PSP.
Great. I think this is our last question, and it says that my wife's PSP diagnosis was confirmed by brain autopsy. What progress is being made to develop techniques to confirm diagnosis non-destructively?
So that is the search that we have for biomarkers. So we want to find either imaging MRIs or proteins that are in the spinal fluid or in the blood, or PET scans imaging that would help us identify the person's disease during life rather than at autopsy. On the other hand, autopsy are very important. One, because it confirms the diagnosis for the family. Two, because if they donate the brain, it can go to research. But I think those two things are important. So families should consider that as a possibility. It is hard at times, and it is hard for me as well, to ask for autopsy, because I'm afraid that someone would understand it wrongly and would think that this is what we're after. But reality is that all my patients have told me, don't be afraid. This is okay. We want to have an autopsy, and I'm glad that you're bringing this up.
Thank you so much. And on that note, I would like to say that as there's a cat. So we are here at Cure PSP, we are actually planning an event to support the Brain Bank Initiative with Mayo Clinic. And it's going to be happening on June 16th next month. We're getting ready to launch that event site. So I would encourage everybody that's watching to please save that date. It is June 16th. So please watch for your inboxes to join us and register, learn more about how to donate your brain, how to donate funds, learn more about research. But in right now, thank you so much, Dr. Litvan, for taking the time to be with us here today to share your expertise and answer questions from our community. And thanks to all of you for watching, interacting, and submitting questions. Like all of our previous Ask the Doctor webinars, this video will be archived on our Cure PSP TV YouTube channel and on our website in the next few days. So keep your eyes peeled for further communication. We are so thankful for you for helping us make this Ask the Doctor series a great success over this past year. And we've had the pleasure of hosting some of the sharpest and most cutting-edge neurologists in this important field. So please go check out our YouTube channel. And if you would like to view previous sessions from medical professionals from our Center of Care Network, in addition to much more educational content. I would also like to make a point to mention that the next Cure PSP Family Conference, which will be a 2-day conference, will be held virtually on May 21st and 22nd. So please go sign up. So if you enjoyed today's bite-sized educational snippet, you will love this 2-day conference. Registration is live. The Springs Conference will feature sessions on topics like neuro-ophthalmology, occupational therapy, emotional support, and self-care, and we'll even have a patient panel. Lastly, these webinars and events are only available because of donations from viewers like you. So thank you all very, very much, and we hope to see you again soon. Have a great afternoon. Bye-bye.
Thank you.